I actually struggled with what I was going to talk about, and you could have completely varying talks up here depending on who gets up in the podium. You can have somebody who makes it sound like the Messiah has arrived, and then you can get others who basically say this is probably a complete waste of time, waste of money. And I struggle with that because even though I've gotten into robotics and I got in relatively early, I'm not sure what the role of robotics is, and I think my talk's going to kind of bear out my difficulties in trying to figure out where this fits in, at least to my practice, and to the field of general surgery. So I sort of stole this title from a talk at the last SAGES meeting, which is the Laparoscopic Society meeting, which was in San Diego a couple years ago, and the keynote speakers who were both really the leaders in robotic surgery kind of went at it. And I think most people walked away not really knowing which direction robotics was heading in, although everyone, I think, wants it to succeed. So despite the fact that laparoscopy has been out since 1989, there's still a lot of stuff that's not getting done laparoscopically. Most of the appendectomies, certainly almost all the cholecystectomies, are being done laparoscopically. Colectomies really didn't kind of catch on till quite late, partly because it's definitely a more complex operation, but also because there was a bit of a moratorium on laparoscopic colectomies for malignancies until they determined whether the oncologic outcomes were equivalent, appropriate, and I think that sort of delayed the majority of surgeons really getting fully into it. So in the last few years, I mean, there's definitely been a pretty significant rise in the percentage of colectomies. It went from about 15 to 31% in the course of 1 year, and I think that's continuing to rise. Additionally, as we train more residents coming out in laparoscopy, I think all these numbers are going to start achieving levels at least up to the appendectomy rate, if not the cholecystectomy rate. But there's still a lot of room for improvement in minimally invasive surgery. So why even bother? I mean, what's wrong with laparoscopy? Well, some people, partly including me, say there's nothing wrong with laparoscopy. If you're well trained, you're really good at doing it. Maybe there's not that much more that you can add to it, or that much better, or the outcomes are not necessarily that much better. And I'm going to go through some of the data that we have on that. But it is a challenging operation to learn how to do. I mean, I was fortunate. I spent a year doing only laparoscopy, and I learned a lot of tricks and a lot of techniques that really helped me get out there and practice. But not everyone has that advantage, and we all know that when you're trying to learn something new and you're out in practice, you don't have the luxury, the time. You can't spend weeks, months, year, let alone a year, trying to learn a new technique. So it's challenging. Ergonomically, definitely can be a very challenging operation. I think it's going to cut a lot of people's careers short because it's very hard on the body. Particularly when you're operating kind of in narrow, deep areas. A lot of, it sounds like playing Twister in the OR. It gets pretty challenging after 3 or 4 hours. There's definite data that says that learning to do certain techniques robotically is easier than learning to do them laparoscopically. Suturing is always the one that's put out there. Medical students learn how to suture 10 times more quickly robotically than they can laparoscopically. But does that translate into a better operation is really the ultimate question. Robotics certainly improves ergonomics. You can sit at at least for the surgeon who gets to sit at the console. You maybe get a little stiff back over there, but the assistant is still standing at the table, and they're the ones that are kind of suffering the brunt of these long operations. Visualization is clearly better. Now, I haven't switched in my plasma high-def TV for a 3D TV because I'm not necessarily sure how much more enjoyment I'm going to get out of that. But 3D vision certainly has some benefits in operating versus a two-dimensional, although very nice two-dimensional picture. And I'll sort of talk a little bit later about how robotics may broaden the ability of surgeons to do minimally invasive surgery. I think ultimately what it may come down to is figuring out where robotics fits in the realm of general surgery. And I'll go through some of the data we have on that. So evolution, the DaVinci robot's the only robot currently FDA approved. There are a couple other robotic systems out there, possibly less expensive, possibly smaller, maybe more room efficient. It's still a pretty bulky device. You need a reasonably good sized OR to fit it in. But the original DaVinci was a very basic machine. It really came out for general surgery. I mean, that was the design was to implement this in general surgery where people had embraced laparoscopy. But they found that it had fairly limited range of motion, limited accessibility to different compartments in the OR, so it basically became a prostatectomy robot. They developed another generation which improved the access to different parts of the abdomen, but still really not quite advanced enough to do a lot of general surgery very easily. Hysterectomies started kind of coming onto the scene, more GYN surgery, and then eventually the model that we have now is the SI model. The benefit of the SI is that it's designed to really kind of be the robot for the future, and instead of having to buy a whole new system, you're able to upgrade, put in different platforms like single incision surgery, and really it's just plug in the computer data and away you go. As far as the number of robotic procedures performed, I mean, that's really skyrocketed as well. Mostly we're talking about prostatectomies, hysterectomies. General surgery has definitely lagged behind, but there's a big focus on general surgery, and at least from the company standpoint, because they've kind of maximized or reasonably maximized where they are with prostates, hysterectomies, and general surgeries. They're big next field. 400,000 robotic surgeries last year. Pretty impressive number considering how relatively short this has been out there. How many hospitals have it now? 1,400 hospitals in the U.S. alone, 1 in 4. Less penetration perhaps in Europe, but the map is really amazing. They have a map at Intuitive which shows the growth over the years, and it's looks like the plague just exploding across the world. General surgery procedures that are done, basically I could have listed everything. I mean, there really is nothing, and honestly nothing, that someone hasn't done or tried to do robotically. So the advantages, certainly visualization, 3D versus 2D. There's future work, I think, hopefully coming sooner rather than later on different types of imaging or light technology, allowing us to see different, even on a microscopic level. The platform itself is very stable, eliminates tremors, which the young guys don't have to worry about, but as we get a little bit older, gets a little more challenging when you're trying to suture after 3 or 4 hours and a couple cups of coffee. Mechanically, the range of motion that you have on the end of your instruments is phenomenal. It's like having a mini hand in there. Reduced torque on the abdominal wall, maybe. I mean, that was it's supposed to fulcrum at a maybe a less injurious manner in the abdominal wall, but I'm not sure I'd necessarily seen any difference in the way the incisions look at the end of the case, or the pain they get from it. And ergonomically, definitely an advantage for surgeons, and that partly was why I wanted to get into it and see if this was a good fit, because you know, frankly, after 4 hours of a case in the OR, I'm physically exhausted and in pain, and you know, the nurses in the OR think I'm having a heart attack or something when I'm rolling on the floor. The limitations of robotics. Obviously, additional training. And like I said, the same thing with laparoscopy, you just don't have a lot of time to go out there and train. And although there is a defined pathway to get to your training or get to your robotics skills, it's not extensive. And you can get into this fairly quickly. So there's a lot of interest now on looking at what adequate training is for robotic surgery. I think right now it's far too little. Learning curve, a lot of people claim it's faster than laparoscopy. I'm not sure that's true. But the learning curve really is surgeon dependent. Lack of haptic feedback, which means that when you're holding something in your robotic instrument, you have no idea how hard you're holding it. You have no idea whether you're pulling on it. There were numerous warnings in your training and injuries to the bowel because you grab a loop of the bowel. Your visualization of the field is coned down a little bit. Not such a problem when you're looking in one narrow area, but if you're doing a colectomy and you're retracting your upper left colon, but you're working down in the pelvis, you can't see your grasper. So you have to learn by visualization and visual cues, how hard you can pull, where your instruments have to be, because that can result in some pretty serious injuries. Still limited on multi-quadrant surgery, which means that you can't just kind of swing around and do one area and swing the arms back. They clash. They're fairly bulky still. So in a lot of cases, you have to undock the robot, move it, turn the bed, redock it. You can get pretty good at doing that. It doesn't take a whole lot of time, but it's still not that efficient. You can't reposition the OR table. One of the keys to laparoscopy is to be able to tilt your table, use gravity to keep your bowels out of the way, and once you're locked in robotically, you're locked in. You can do a whole concert of movements to kind of get your table tilted, but it takes you 2, 3, 4 minutes instead of just being able to zip the table down, do what you want to do, zip the table back up. So again, when you're trying to do more complex surgeries, there's some significant limitations that I've encountered with robotics. This was sort of the backlash against robotics in gynecology. The president of the American College of Obstetrics and Gynecology basically came out and said we shouldn't be doing robotic hysterectomies for benign disease. And they should all be done, either laparoscopically or vaginally, cost less. It's just as good. And while that sounds like a reasonable statement, you also have to realize that not that many gynecologists are able to do a laparoscopic hysterectomy. Same way that the urologists, very few of them were doing laparoscopic prostatectomies. So you might say, it's all well and good to say it's less expensive to do it laparoscopically, but if you don't have that ability, then you're stuck with doing a bunch of open surgeries. And we know that minimally invasive surgery is better than open surgery. And I'm going to run over. Sorry, Donna. So SAGES put a consensus statement out 6 years ago, kind of a half and half. Technology is great, but if you're a really good laparoscopic surgeon, maybe it's not really going to benefit you all that much. But for all the rest of the surgeons out there, maybe this is an easier way to get into minimally invasive surgery. And I think, there's a pretty good argument for that. The converse to that is that it tends to be easier for a good laparoscopic surgeon to learn how to do robotic surgery and a longer learning curve for someone who doesn't do laparoscopic surgery to get into robotics. So, it's a tough answer. New England Journal did, put out, whenever the New England Journal puts out an article, that's what sort of makes the news, and then everybody hears about it, basically saying that if we converted everything to robotic surgery, it's going to end up costing $1.5 billion just for the procedures alone, not to mention the cost of the robots. And that's probably even underestimated because you'd have to buy a bunch more robots to be able to do all the surgeries robotically. So $2.5 billion a year, at least, if you were going to move to robots. Now, they didn't look at what the overall cost savings might be if you did everything minimally invasively, because we know that does save costs. But as with everything, we haven't done any studies to look at it, so these are all mostly opinions. But there's a lot of kind of this going on now, who's right. So I'm going to I can go through the data pretty quickly because the bottom line is there's almost no data out there that says that robotics is superior to laparoscopy. And most of the data says that it takes longer and costs more. So why are we doing it? Well, first of all, it takes a while to get a lot of good data. So this is, somewhat early data, although we've been doing it for many years now. Surgeons are actually really bad at putting good studies together. The benefit really seems to start to show up in specific areas. So they looked at 12 robotic surgery or general surgery procedures done robotically, and it starts to kind of come out that in colorectal surgery, particularly for rectal surgery, maybe there are some benefits. But for basic surgeries like cholecystectomy, hernia repairs, there really doesn't seem to be any benefit at all. Except that the caveat is, those are the procedures that are easy to do, and if you're going to learn to do robotics, you got to start on the easy ones. So most of these studies, very flawed. They're all retrospective. They're not good studies. There's just, such a dearth of good data out there. They went through, another study went through all the different fun applications of myotomies. So there's 3 studies. One study showed decreased number of perforations doing robotic Heller myotomies. I can tell you I've done probably 40 or 50 myotomies, and I've had 2 perforations, both of which I sewed up and had absolutely no sequelae. So, maybe the robot's going to cause fewer perforations, but most of the perforations don't have any clinical result or outcome. So again, these studies just are not that effective at getting, of determining what we should be doing or whether it's better. Colorectal, probably the one area that does show some benefit is in decreasing the conversion rate. So both for colorectal, gastric surgery, pancreas, the one thing we can say is the robot does seem to reduce the need to convert to an open procedure. I'm going to pop through these, sexual urinary function, and again, this is not a case match, not a prospective randomized trial. They looked at 74 of their patients and found that their urinary and sexual function came back to pre-op levels at a year. Obviously, that's a good thing, but there's no comparison either to open surgery or directly to laparoscopy, so we don't really know if that's better or not. Amazingly, in Pittsburgh, they've done 250 pancreatic robotic surgeries. I don't know that we've done 250 pancreatic surgeries in the history of Tri-City. Great numbers. I mean, it's, the mortality's low, the complication rate's low, conversion rate's low, leak rate's about the same that you get with open surgery. But that's a pretty long time. Most good pancreatic surgeons are doing Whipples in 3 to 4 hours. So, that's almost 10 hours of operating in many of these cases. They also looked at their distal pancreatectomy. They, again, compared it with their prior surgeries and found that they had more lymph nodes, better margins. But, what does the future hold? Is it going to be this guy, giving a talk, coming to see you in the OR or in the hospital? I think this is sort of my message. It really may create new opportunities for surgeons who want to get into minimally invasive surgery and are not able to learn laparoscopy, not good enough, not hand-eye coordinated enough, too much tremor, what have you. This may be the way for them to get into it, and that's not necessarily a bad thing, but I think we have to watch that carefully, and we have to train them well. Also, there's a lot of hype about the future of robotics, and I'm going to sort of end with the hype. And this is kind of where you hear everybody sitting around the table saying, "Yeah, but just wait." Now we've been doing robotics for over 10 years now, and definitely gotten better. But there's a lot of just wait. Single incision came out a couple years ago, so you can take a gallbladder out through somebody's belly button robotically. It's a fun, pretty easy case to do. Doesn't take that long. It's a nice cosmetic outcome, but that's it. It's a cosmetic operation, and we're starting to see a higher incidence of hernia rates from those single incision sites because it's a bigger incision than a laparoscopic port. So there's definitely pros and cons of that. The idea is that single incision surgery is going to take over all of robotics, and every operation is going to be done through a single incision site. If they get to that point, now we might be talking about some significant benefits to the patient. But they hold everything close to their vest, so I have no idea when that's going to come. There's a lot of technology that has to improve on that, but we keep getting told, wait, it's going to come. There are some other very interesting applications, fluorescence imaging, which you can do laparoscopically too, but you flip a button and you get a fluorescent picture in your video monitor. It does help you see vascularity. You can use it for partial nephrectomies, but for colectomies, for bile duct imaging, and if you're really talking about now some potential patient outcome improvements, lower leak rates, getting injuries to the common duct, if you can see ureters real time, I think there could be some significant advantages if you can incorporate this technology and it's proven to work. A lot of other little things coming along too. And then maybe if we get to the day where you're literally just loading your app and away goes the robot, then I'm going to be a happy man.